Okay, good afternoon and good morning or good evening, depending on where you are in the world. Thank you for joining us. This is the sixth session for the Neonatal Hemodynamics Foundations curriculum. We're excited today to introduce a speaker who needs no introduction. But first, a couple of housekeeping issues and a description of a change that has taken place, hopefully for the benefit of all of the trainees in neonatal hemodynamics who are joining us and are to some degree the primary audience for this foundations curriculum. But starting with this session, we have invited the trainees in neonatal hemodynamics in the programs around the world who are joining us to join these sessions as panelists. And that's why you may be seeing them, or if you're part of them, you'll be seeing yourself on the broadcast. They are the ones who are going to be on camera, and we encourage and ask that the trainees do keep your cameras on throughout the session, when feasible. Those of us joining who are not a neonatal hemodynamics trainee, obviously you're very welcome to join. However, you are going to be off camera and we'll be able to interact through the Q&A box. And so please, if you are not a hemodynamics trainee, please do submit your questions, and I will be sending them to the speaker through the Q&A chat box. For the trainees who are panelists, you'll be able to raise your hand if you have questions at the end and unmute your mic and ask the questions directly and interact with our speakers. And I'd like to point out, Laura, if you could move please to the next slide, that the Foundations curriculum is supported by an unrestricted educational grant from Mallinckrodt Pharmaceuticals, and we're grateful for their support. And now to introduce our speaker, Dr. Patrick Mcnamara is a professor of pediatrics at Iowa Children's Hospital. He is a legend in neonatal hemodynamics and one of the fathers of neonatal hemodynamics around the world. We're grateful for him to be speaking to us about patent ductus arteriosus, and I'll hand it over to you, Patrick. Thank you very much.
Thanks, Danny. I don't like the word father. That makes me sound like I'm really old.
Well, many of us are fathers, and we're not that old.
Yeah, that's okay. I'm okay with that. So thank you for the introduction today. I certainly welcome the change in the format. And again, I have to be full disclosure. I was probably the most vocal person in actually trying to make this change happen, because we have many lectures. We have the Pan American webinars. There's all sorts of different types of scenarios. And what we had envisaged for this session was a interactive forum whereby, in a less formal way, the trainees can get to interact with a wide range of experts on different topics and different domains. So while I have a talk, and I will try to get through most of that talk, I want this to be interactive. So the one thing Danny has not heard is I may call on you and have questions. So I want, and don't be afraid, at the end of the day, this is a safe environment, and I want people to know that there's no wrong question. Okay. The one thing in medicine, and particularly in neonatology and neonatal hemodynamics, is, what we have learned mostly in the last 10 to 15 years is how little we know. I think that's the most important thing. There has been a lot of dogma and certainty, oftentimes evangelical certainty over many topics. And when you actually look into what is the justification for why we do what we do, or why some people are pretty strong in their conviction, there's actually not a lot of evidence to support the vast majority of things. And part of the reason for this was a disconnect between the people who are interested in solving the problem, meaning the neonatologists, and the individuals who had access to tools like echocardiography and their interest in studying those problems, okay? And over the last 10 to 15 years, obviously there's been a major paradigm shift in thinking. And we continue to think, and even for myself, things that I published on 10 years ago and said, this is what we think is going on, today we're actually realized that that was not correct. So we're only as good as the information we have, and information and data is good, okay? But the field will continue to evolve, and this is what makes me very happy to see the interest from many people from many different parts of the world who are actively involved in trying to understand hemodynamics and so forth. 15, 16 years ago, when I first gave a talk in the US about this concept, I was told that this is fantastic, but it's only going to ever happen in Canada. It's never going to happen in the United States. We are so far from that now. There's a momentum, there's interest, there's appetite to do this. And people recognize that they don't have the right information. Okay. So my topic is the ductus arteriosus. It's a very simple, straightforward topic that we know the answers for, and this probably will be a 5-minute lecture that will be all done. Okay. And all of you know that it's probably the most controversial topic in neonatal hemodynamics. And much of the controversy relates to, one, people having viewpoints in which they're pretty intransigent on both sides. And secondly, and excuse the word, but ignorance of understanding the problem and understanding that the problem is not a static problem, it's very dynamic. And if you don't remember anything I say today, the one thing I want you to remember is that hemodynamics is physiology. And if you're interested in hemodynamics, you have to be an expert in physiology. And every day when we do our hemodynamics reviews here, the vast majority of the discussion is about physiology, physiologic concepts, getting people to think outside the box and so forth. So I'm going to start off. Let me just share my screen. Give me a thumbs up if you can see it. Okay. Okay. So I'm going to start off with a case. Okay. And this is a real case of a, sorry, does somebody have a question? Okay. So a 26-week outborn infant, born following placental abruption in a community hospital. The infant was asphyxiated, difficult resuscitation. It took them a while to intubate the baby. Eventually they did. And the baby got surfactant. You see the x-ray on the right-hand side. The baby from a lung perspective did relatively well. But on arrival to our program was on dobutamine. This is his blood pressure. And these are some of his vitals. So my first question is, what do we think is going on? What are your thoughts physiologically as to what the issues might be? And all I would say to you is just be careful. The session is called PDA. Those of you that know me is that I don't deal with the simple. I deal with the curveballs. So who's brave enough? One thing, if you want to be a hemodynamics person, you've got to have strong conviction.
Yeah, I may just suggest things.
Sure, go ahead.
Now, number one, looking at the the abnormalities here is obviously poor color and perfusion. So there is and kind of lowish blood pressure, mean blood pressure, but the systolic and the diastolic are kind of acceptable. So I can see also the hemoglobin is low for sure, and there is high lactate. So there is evidence of shock, maybe I can say shock, or just like poor perfusion and poor color. So looking at the X-ray, what I can see is like hyperinflated chest, like the lung inflation is up to 3, 4, 5, 6, 7, 8, 9-ish, but the mediastinum and the heart looks narrow. So probably that could explain the reason why we're having a low kind of systemic blood flow, maybe. I mean, just, like given the poor color and perfusion, given also the high lactate, but also with low hemoglobin, which could be explained by IVH or, placental abruption, like the history of placental abruption.
So lots of information there. I'm going to push it back a little bit. So you made a comment that the baby's systolic and diastolic blood pressure are okay. For the rest of the people, is that a normal systolic blood pressure? What is a normal systolic blood pressure for a 26-week infant?
Usually I look at the the blood pressure kind of chart with the age, but given the mean is 25, we usually say it's like around the age, like the age in weeks, like, gestation age.
Okay, so the first comment I would make, and again, please other people jump in. Again, it's a talk in itself, blood pressure. I'm not going to be talking about blood pressure, but all I will tell you is our thresholds for defining mean blood pressure have no scientific validation to support them. They're a guide, okay? And that systolic blood pressure is very low, okay? A 26-weeker probably should have a systolic blood pressure at least 35 and above. I can't remember the exact number, but it is low. Now, the next question I have for you, in an asphyxiated infant, how reliable is lactate as a measure of systemic perfusion if you're asphyxiated?
I know it's not as reliable as in older infants, but it just, adds to the... Yeah.
So again, just some additional teaching points for this perspective. So, so again, this is how we think about blood pressure, and you've pretty much articulated some of the major issues here. We need to think beyond blood pressure. Are there clinical signs of a low cardiac output state? Which there are, but obviously there are some limitations in someone who's potentially asphyxiated. But looking at the separate systolic and diastolic blood pressures may give you some initial clinical physiologic tools. And that becomes very relevant when you're selecting drugs, okay? So if the problem is a very low diastolic blood pressure, you shouldn't be immediately thinking about, oh, I need to give a drug to support heart function that's a vasodilator. It doesn't make a lot of sense, okay? This infant has got low systolic blood pressure. That diastolic is not that bad for a baby at this point in time. So if you think about systolic blood pressure, keeping it very simple, blood can't get into the left ventricle. The left ventricle doesn't do its job of contracting. Our blood can't get out because of afterload, okay? So it's complicated. I'm putting this up intentionally because our approach is very much driven by simplicity. 1 or 2 drugs, in most places, 1 drug is your starting point, which doesn't necessarily recognize this complexity of the physiology and the diverseness of the possibilities. So you mentioned that the baby looked a little hyperinflated, and I agree that it did look like the lungs were pretty well aerated, which may impact filling of the heart. A high mean airway pressure may compromise filling of the left heart, okay? But there are many, many other things here that can explain what's going on. So quickly moving on, this was the baby's echo, okay? And what we identified for simplicity is that the infant was in a low cardiac output state. His right ventricle was functioning adequately, but his left ventricle was contracting very poorly. Okay, both his ejection fraction and his LV strain were abnormal. So how might you treat this? Somebody else.
Can I answer this question?
Yes, anybody can answer the question.
Okay. So my name is Ayman and I'm a TNA fellow from Ottawa. So giving the scenario, I would start for this baby first on giving blood products. So starting with packed RBCs, probably 10 cc or 15 cc per kilo. And the dobutamine here, which we are using at 5, probably is not the best choice because we have the systolic blood pressure issue and the function probably is not poor, given even the HIE picture. So maybe we need to think about something else, which is, I don't know exactly what, but my assumption is starting with volume will be the key for this case.
So I think that's very reasonable. Fixing the blood is obviously important. The heart, obviously, the Frank-Starling law is a little blunted in babies. You don't get giving high central venous pressures or high atrial filling pressures doesn't necessarily make the big ventricle contract better. However, being in a kind of a state of suboptimal hemoglobin is not a good thing for someone who has heart dysfunction. The one thing I will tell you is that, dobutamine is not an unreasonable thing to start with in someone who has heart dysfunction. It's a very clean drug. But what we've learned over time is that if your heart function doesn't recover by 7.5 to 10 mics of dobutamine, going up and up and up just makes you tachycardic and doesn't help enhance the heart function. So this particular baby here, we transitioned from dobutamine to low-dose epinephrine. Okay, this was the plan. Now, this infant is 3 hours old. Just keep that in your mind, 3 hours old. Okay. Over the next 3 hours, the infant started to seize. Phenobarb, lorazepam, multiple drugs, and now is in 100% oxygen. Has got significant mixed acidosis. His blood pressure recovered. So we fixed the blood pressure. So, thoughts? What are we thinking now? Somebody else. Oops.
Okay.
There we go. Already gone. I don't think you saw it quick enough.
Can I answer? Or?
Let me know somebody else. I want somebody else to answer. Okay, I'm going to start calling names out.
So I'll volunteer then. I'm Danielle Starenko. I'm a neonatologist and an echo fellow in Halifax. I would be worried about pulmonary hypertension in this patient as the cause of the hypoxic respiratory failure.
Okay. All right. So quickly moving on. This is a PDA session. Okay. So you're absolutely right. Okay. So the physiology changed. So you can see the LV ejection fraction recovered nicely, but the infant has got a wide open duct with predominantly right to left shunt. His RV function now is very bad. TAPC of 2, which, as you know, so the right ventricle contracts longitudinally from top to bottom, which is why we use TAPC as an index of contractility. And his RV fractional area change was 20%. So what are you going to do? He's got pulmonary hypertension. You're on epinephrine. How are you going to manage him?
So I'd be looking for some pulmonary vasodilation. I'd probably start with inhaled nitric oxide and kind of keep milrinone in the background as another option, just as I have found it causes a little bit more systemic dilation than the INO does.
Okay. So this is what we did. Okay. But when we use nitric oxide in preterm babies, the one thing that we pay very close attention to is the postductal blood pressure, particularly in infants that are nitric oxide responders. And in this situation, the team chose 20 parts of nitric. I actually sometimes use just 5 parts of nitric because the rapidity of the response in some preterm babies is such that I worry about the physiology changing too radically, and particularly going from a state of low cardiac output to a state of very rapidly increasing cardiac output from a brain perspective. Okay. Now, the reason I put this up here and why this is very, very important is the AAP tell us there's no role for nitric oxide in preterm babies. And it's because of this. Studies like this, which came from the Buffalo group. And if you look at the percentage of infants who are responders of those that have received nitric oxide under 28 weeks gestation, the percent of response is much, much lower. So how do you reconcile that? So what's the fallacy in how people have traditionally thought about the use of nitric oxide? So if you were to ask one question, I'm going to pick on someone, Angelica, one question, what would be the one question you would want to ask about here in this study?
I would want to know how they, well, number one, how they diagnose the pulmonary hypertension and the ductal direction at the PDA, or shunt direction at the PDA and at the atrial level.
Okay, so you've answered the question, but in not exactly the right way, but you have said the right thing. The question you would ask is, do you have pulmonary hypertension? Okay, we have traditionally translated hypoxemia or hypoxemic respiratory failure into you have pulmonary hypertension. And you may not have. There's many reasons that you may be hypoxic. You may have lung disease. You may have too much pulmonary blood flow. You may have too little pulmonary blood flow. Okay. And the answer to the question here was these patients did not have echo. Okay. This is a study that was done based on the fact that you receive nitric oxide. And the more immature you are, the more likely the probability that there's many different reasons for why you have hypoxemic respiratory failure. So, which is what prompted us to do this study in Toronto, just very, very briefly, when you actually homogenize the population and you look at those who have confirmed pulmonary hypertension on echo, the odds ratio of a positive response to nitric oxide is much, much higher. And this has been our clinical experience. If you treat the problem, the patient gets better. If you guess what the problem might be, you may not improve. So what happened to this baby? Exactly what we suspected. He responded very rapidly to nitric oxide. Okay, this is now 3 hours later. 3 hours later, he's in room air, but he has a postductal blood pressure of 31/16. And the reason for that is on the right-hand side. You've got now a large left to right ductal shunt, which will mean that your postductal circulation or your postductal cardiac output has fallen. So when we use nitric oxide, or when we're managing infants with pulmonary hypertension, we always look at pre and postductal blood pressure to look at the differences in the blood pressure response to treatment. Because it'd be very easy here to say, oh, we now need a pressor. I need to now give another drug to make the blood pressure go up. What we did was wean the nitric oxide off. So within 6 hours, this echo was done 6 hours later. So now, within 9 hours, we have gone from LV dysfunction to RV dysfunction with pulmonary hypertension to PDA physiology. And why I share this with you today, and again, I'm speaking to an audience that their a priori commitment to hemodynamics is very, very high. But in a program that does not have longitudinal echo, you have no idea that the physiology has changed 3 times. And you're just throwing drug after therapy in a very blinded manner without the precision that you need. So the question for today is, you've got this infant now with a big left to right shunt. Okay, QPQS is almost 3:1. All the markers are abnormal. You've got a high volume left to right shunt. You're off nitric oxide. You're on a little bit of epinephrine. What do you do now? And again, if you're a disciple of everything that the AAP says, you will not do anything because the ductus is never left to right on the first day of life. these infants all have pulmonary hypertension for the first 7 days of life, which we know is not true. Okay, so any questions about the case before we move on? And I'll come back and I'll tell you what we did in this situation here a little bit later.
There was a seizure in the history, so did we check the brain?
Yes, so the baby was on amplitude integrated EEG, clearly had evidence of hypoxic ischemic injury, went on and got an MRI kind of a few days later. But it's a very, very good question because you have an asphyxiated brain. You have a brain that's gone through a period of hypoperfusion. Now you've got torrential PDA physiology, which means that the brain is being hyperperfused. You've got remember, the brain is perfused by the preductal cardiac output, which is high. So the potential for intraventricular hemorrhage, theoretically, is likely to be much, much higher here. And, I wonder how much of the significant IVH that we got in the early trials of nitric oxide were because we gave it at high dose, we left it on for patients with wide open shunts, and they've got now all left to right flow and high flow to their brain. Is that why they bled? I have no idea, but it's possible. That's a very good question. So this is all about phenotypic profiling, okay? And we need to move from thinking of symptoms as things that you need to fix as symptoms to what is the phenotype? What's the physiologic or clinical phenotype? And provide an intervention specific to the phenotype. This is the only way we're going to get better. This is the only way we can modify outcomes from that perspective. And why it's important, and this is just a concept, okay? And it's not rocket science. If your diagnostic precision is high, the balance is going to weigh towards therapeutic efficacy, and the probability of adverse effects will be less. But if you provide an intervention based on low diagnostic precision, efficacy is likely to be less, and the balance will weigh towards adverse effects. And this becomes very relevant when you start thinking about PDA, because if you don't clearly identify that the problem is a problem, and you enroll babies in trials and studies with a low probability of complications or consequence, you dilute the possibility that you're actually going to find a benefit in any form of trial design, okay? So this is very, very important. Randomized trials are important, but hemodynamics is physiology. So to design a good study to test a hypothesis in something that's dynamic, you have to have a high degree of rigor in identifying what the problem is. So it's kind of a little surprising and shocking that it's now almost 70 years since the first report that the ductus was associated with significant respiratory instability. This is the Mostyn Powell study from the Royal Women's Hospital in Melbourne, in which they reported 6 preterm infants who were a little older, who were 4 to 6 weeks old, who had respiratory disease that wasn't going away. And if you go back and look over time, this is some work from Stephen Palder in the late 1970s, where they looked at infants who developed late onset NEC, and basically found that if the ductus had been closed prior, the infant was more likely to survive. Infants who developed NEC but had a persistent wide open shunt were much more likely to die from this era. And again, looking at the data from the 90s, George Cassidy's randomized trial of PDA surgery showing a reduction in NEC, Ron Kleiman's meta-analysis, again showing that early intervention perhaps is better. One would think we've solved the problem. The evidence seems to be very much pointing towards treating the ductus seems to eliminate morbidity. But it's not so simple. And if you look at data over the last 10 to 15 years, you can see that there's been a secular movement away from medical and surgical therapy, mostly surgical therapy. Most of the paradigm shift has been away from surgery. The rate of medical therapy has not fallen to the same extent. but the growth of this concept of conservative therapy, which is something that we've really not well defined, and it's interpreted very differently by many people, from physiologic maneuvers to modulate the shunt, like any kind of circulatory imbalance, to, in some centers, there's no point doing anything. I don't need to do an echo. The ductus is unimportant, you know. So, and that's a little problematic to try to then study, because if you don't ever identify the problem, it's very hard then to tease out the impact of that intervention. So why have we moved to this point? And there are some very, very evangelical people who have very strong opinions. But what's interesting to me, and most interesting, is that most of the people that have very strong opinions are not necessarily people who have given their lifeblood to cardiovascular physiology, cardiovascular research, science. It's very much driven by kind of an appraisal of kind of trial data and so forth. So what is the evidence to say that perhaps we have overdone things? And I honestly think that in the past we have overdone things. And Bill Bennett's, in a recent lecture I gave sometime last year, and I was a little surprised when he said this, but he said, I am a proponent of conservative therapy. And I didn't quite know what he was talking about. But he's right, because what we have done is we have created a milieu in which we've been much more selective. So moving from treating everyone to be more selective is relative conservatism. So what were the rationales? So the first was spontaneous closure will occur. And if you look at Jan Milliton's study from Ireland, you can see that more mature babies, the ductus is likely to close spontaneously. However, once you go down to the infants who are less than 750 grams at birth, the probability of spontaneous closure early becomes a lot less. So the three questions that need to ask are: one, is exposure of 50% of babies to an average of 50 days an acceptable risk? Two, one of the limitations of this study was that babies who died early in the first week of life were excluded, many of whom may have had the problem. And three, and this is a really, really important one that we've paid no attention to: how does spontaneous closure occur? Is it natural PDA remodeling, or is it in the face of pulmonary vascular remodeling? You increase pulmonary vascular resistance, you decrease the pressure gradient across the ductus, leading to decreased flow, allowing closure to occur. This will be beneficial. This may be harmful. So my next question is, what's different about closure of the preterm and term ductus? What's different? Is the preterm ductus designed to close? Let me answer the question another way. Who's going to have a go at that? Somebody else. Be brave.
Hi, this is Pearl.
Okay, Pearl.
The term and preterm ductus are different. The preterm ductus are not designed to close spontaneously.
Okay, so what's different about them? What are the three developmental differences between the preterm and term ductus that make it less likely to close spontaneously?
Well, the term ductus has thicker layers of the myometrium layers, and that the endometrium of the term ductus is more convoluted and has the vessel, the vasa vasorum that can initiate like the closure of the ductus.
Okay, that's correct. Very good. So again, thinner muscle layer, which means that it's harder for the muscle to contract. Secondly, the intima is smooth it's not convoluted. So opposition of the sides of the ductus is a lot harder to occur. And then thirdly, the vasa vasorum, which are blood vessels that provide nutrition to the wall of the ductus, are not present to the same extent in preterm babies. So biologically, it's not set up too close, okay? Now, in saying that, we've seen infants who are 22 weeks gestation, 400 grams, whose PDA is closed at 6 hours. It does happen, and that's why patients are individuals, and there's probably genetic factors also that are important here in terms of closure. Second, ligation is associated with adverse outcomes, and I'm not going to get into details about this. That's a lecture that Danny can give to you. And then third, the trial data. And the evidence is very clear from the trials that PDA treatment decreases patency without modulating outcomes. And this is where the controversy arises. So, so when I was asked back in, this is now over a year, at the AAPNC meeting, a 1-month-old baby who's on a ventilator with a moderate-sized PDA and left to right shunt, would I close the ductus? What do you think I said? I'm going to start calling names. Okay, Karen. What do you think I said? Did I say yes? Did I say no? Did I say I don't know? Anybody?
We don't know.
You say it depends. You might have asked for more details.
Yeah, that's exactly. You didn't know, I didn't know. I had no idea. I don't know if the problem is a problem. That's what I said. And this is key when you're thinking about trial data. Is the trial relevant to the patient that you're taking care of? That's a really, it seems very basic, but we oftentimes don't do that. So in the studies, was there standardization of the problem? Did we have control population? Is the data relevant? We would not make a study, we would not make a decision on the basis of a study done in 1921. Okay, we would say that's outdated. But neonatology is changing radically. So when you look at the trials, this is from Kurt Duvall's group, they did a meta-analysis. High proportion of the studies did not involve echocardiography. And the most common entry point was patency of the ductus arteriosus. So if you want to think about the PDA, the first question you need to think about is, what is its role? Is it pathologic, which we're talking about today? But there are many situations in which the ductus has a beneficial role because there's heart dysfunction. And if you are randomizing a baby based on the presence of a murmur, you have no idea if the RV is dysfunctional, the LV is dysfunctional, if you have subclinical pulmonary hypertension. And in those roles, the ductus is probably beneficial. This degree of detail and precision was missing from the vast majority of the studies. Some of you may have seen this before, and this is what we paid a lot of attention to over the last number of years, is that, a lot is decided on the basis of the diameter of the ductus, which is a 3-dimensional structure that we simplify to be a 2-dimensional entity. And those of you that are performing scans know that you can make the duct look big and small. You can make it look whatever you want, depending on the view that you take. If your eyesight is poor, if your equipment is crappy, you may not be able to see the ductus well. And Fernando Martins, when he was in Toronto, looked at a whole high volume of echoes, and when we looked at the correlation coefficient, diameter and LAO ratio performed very, very poorly. And when you look at the relationship of diameter to all of these physiologic indices of hemodynamic significance, you can see that the R-squared values are very, very poor. So diameter is important, but it's not the only thing. And it's not the only thing, because what governs flow? What governs flow across the ductus? Who else that has not spoken?
Wouldn't this go back to that physics equation with surface area and resistance in the radius of the PDA?
Okay, so your absolute answer is in physiology, okay? And yes, it's an equation, and we'll come back to the equation later on. What you're talking about is the Hagen-Poiseuille law, which is influenced by pressure gradient, length, diameter, and viscosity, which are all the determinants of flow. And that's why you will not see a perfect relationship ever between diameter and any of these variances of these entities here. Okay, PDA comes in all sorts of different shapes and sizes. And why that's relevant is, again, going back to our assumption. When you're measuring the ductus, we measure it at its narrowest point, but we're assuming in cross-section it's circular. And as you can see on the image on the right-hand side here, it's not always circular. So depending on your imaging plane, you can make the ductus look big, or you can underestimate it. And that's really, really important. And this is one of the reasons why, when we're evaluating, we look at the ductus in a much more comprehensive way. Okay. Did the trials include a control group? Up to 50% did not. So we're not randomizing treatment versus no treatment. We're randomizing treatment versus treatment at another time. And again, finally, is the data contemporary? And what you can see here is that in the meta-analysis, the vast majority of the studies are pre-2000. Median year of publication, 1994. Okay, soon somebody is going to say I wasn't even born in 1994. Somebody's going to say that very, very soon. But neonatology, I started neonatology in 1995. It is radically different. The babies we took care of then, we were not doing what we're doing today. We did not have nitric oxide. Okay, there were no 22, 23 weekers in any of these studies, different ventilators, et cetera, et cetera. So I would argue that the data is not relevant, that probably what we should be doing is focusing on trials beyond 2000 and let these trials expire. They're no longer relevant. The patients in those studies are not relevant to who we take care of today. Equipoise is a huge issue for clinicians. This is the PDA Tolerate trial. Up to 40% of eligible patients, the clinicians did not randomize because they had a bias. And what was most interesting was, although the primary trial showed no difference, the babies who were not randomized, who were sicker, smaller, had better outcomes. And they were treated early. That's an important concept. The other concept, and this is, we're just at the infancy of our thinking about this, but this is something that's really, really important. We translate the meta-analysis of medical therapy and the conclusions as if medical therapy has solved the problem. And we know that up to 40 to 50% of cases, it doesn't solve the problem. And this is the post hoc analysis of a Afif Al-Kafash's small study in Ireland based on an early PDA score. But again, it's got some interesting hypothesis generating data. If you treat early and you solve the problem, those babies do better. Their risk of survival or significant BPD is lower. And the pivotal trial is going to be a really, really important trial in neonatology. Again, this is Carl Bacchus' study looking at randomizing babies on day 7 to definitive PDA calf closure versus conservative therapy. This will give us the most insights because you will be solving the problem. There's going to be no debate as to whether or not medical therapy was efficacious. So, summary at this point in time is to better understand the problem, we need to think of the physiologic consequences of the problem, and in trying to develop better evidence to say whether treatment is beneficial, we need to at least ensure eradication of the physiologic instability in whatever means that is. But this is the best way to test the hypothesis that medical therapy is of benefit. So how do I think about the ductus? Well, for me, in thinking about the PDA, and particularly if we start thinking about BPD, there are two things that are important: the magnitude of the shunt and the duration of the shunt, none of which have been addressed in any of the trials. We've not looked at any of this stuff. And in particular, if you're thinking about BPD, if you look at flow in the pulmonary veins here, on the left is a closed duct, on the right is a wide open duct. And this is obviously an extreme version here. This infant has extremely high torrential pulmonary vein flow, which is what you would expect in a very large shunt. Now, why might this be important? It's very important because of something that we have paid no attention to. Everybody on this call today, without exception, works in a place where we are obsessive at trying to minimize oxygen exposure. We don't want to give babies too much oxygen. We don't want to keep their SATs high because it's bad for the lungs. It's bad for the vessels. Yet, when you recirculate maybe up to 60 to 70% of the blood back into the lung, this is not hypoxic blood. This is hyperoxygenated blood with a high PO2. And we know from other domains that hyperoxia or hyperoxemia is associated with intimal thickening and medial wall hypertrophy. And I think the next era of understanding the ductus is going to be characterizing its impact on the pulmonary vascular bed, even more so than the parenchyma. So what evidence in terms of the lung do we have? Well, we've got data from the primate model where preterm baboons were randomized to medical therapy, which led to a normalization of QPQS, improvement in lung compliance, and better alveologenesis. This is Danny's very elegant comprehensive analysis of a cohort of infants in Toronto, very high volume of patients, looking at infants who required ultimate surgical ligation versus those that were, again, had significant shunts but were medically managed. And you can see a separation in the groups. And again, what I take from this is that the babies with the worst shunts, very early on, they distinguished themselves as looking different in terms of their respiratory physiology. Ron Kleiman recently showed very nicely that duration of exposure, again, is very important. Infants who were mechanically ventilated for a longer period of time with larger left to right shunts were more likely to have more severe grade 2, 3 BPD. And I think in trying to solve the problem of the relationship of the ductus to BPD, I think we've made the mistake of looking just at BPD. Does it really matter? Are you going to throw out a therapy because someone is on 10 cc's of oxygen at 36 weeks gestation? Or do you want to minimize babies who have prolonged respiratory support, prolonged need for mechanical ventilation, assisted support, need for pulmonary hypertension therapy? Those are the things that we need to be thinking about, not a trivial amount of oxygen exposure. The Italian group, again, showed that when you look at the more severe, this is based on our staging system from 2007, infants with the most pathological shunts for the longest period of time seem to have a higher incidence of the composite outcome of death or BPD. Again, very briefly here, I'm not going to go into details here. This is from our Iowa cohort showing a relationship between, again, prolongation of high volume shunt exposure has a high sensitivity and specificity for predicting severe RRP. And this is very interesting because we've not thought about this before. Going back to the same analogy of the lung being exposed to too much blood with oxygen. In the presence of a large left to right shunt, so is the eye. The eye is receiving the preductal cardiac output. It's getting more blood and more blood with a higher PO2. We've not seen anything come out in randomized trials yet, but we've really not looked at the right patients. So again, this is hypothesis generating data. This is some recent data from our cohort here that we're going to present hopefully at PAS, but infants who had the most pathologic prolonged shunts seem to have smaller heads. Their head growth seems to be impacted. So lots of new data coming out. I think the more centers that are doing more comprehensive imaging are more likely to help provide more additional insights. Let me just touch for a minute on pulmonary hypertension, and I'll stop to see if there's any questions at this point in time. 1953, first report, prolonged PDA shunts are associated with pulmonary hypertension. And now that we're in an era of sending babies to the cath lab for PDA closure, we're starting to get actually some realistic insights that prolonged exposure may be associated with dysregulation of the pulmonary vascular bed. Here's an image of a baby on the left-hand side. You can see he's got a very nice piccolo device that's well placed. But Shamsat and Andan in Memphis, who have the largest experience of PDA cath closure, did this very nice study where they looked at respiratory recovery according to time or age at PDA closure. And what they found was that group 3, infants who had cath closure more than 8 weeks, had a longer time to respiratory recovery. Now, what was even more interesting was they did cardiac cath on all these patients and basically found that that same group who had the most prolonged exposure had higher PVR, suggesting that there is indeed at least some reasonable concern that leaving big prolonged shunts open in the wrong patient may not be good to the pulmonary vascular bed. And one of the things that caused me some recent alarm was the paper from the pediatrics group looking at what happens to infants who go home with a PDA. And their numbers weren't very, very large, but what was particularly concerning was that there were several babies who were discharged in some low flow oxygen with the PDA who died from pulmonary hypertension after discharge. That's a little scary. So I think we really need to pay attention to the relationship of shunt to pulmonary vascular bed. So what happens when you stop treating? And again, over the past year, we've had 2 very important pieces of data, one from the group in Montreal, which tell us that the ductal story may be an issue really of the smaller babies, and I agree with this. What they found was that in an era of conservative therapy, the composite risk of death or BPD, and in talking to Gabriel, we also have some data that the risk of chronic pulmonary hypertension also has increased in this same era. And this is not just one center. The group in Miami, again, found a very similar thing. Increased risk of death or BPD. Now, what's particularly concerning to me about this is in the history of neonatology, we have always gone forward. Even when we have interventions that don't make a lot of difference, we don't generally go backwards, okay? Here we seem to have gone backwards, despite advances in ventilation, et cetera, I think we really need to pay a lot of careful attention to this. That going from one extreme, which is closing every duct in every baby, is not a good thing. Equally, going to closing no PDAs in no baby is not good. Extremes are never good in anything in life. So I think that's the lesson that I've taken from this. But we still need to design or get better data to better understand this patient population. So how do we move the field forward? Well, first we need to recognize that there are morbidities that occur in the first week. If you only treat on day 7, you're never going to modulate these outcomes. BPD and NEC complex, there's many confounders. And BPD in itself, what is BPD? I'm not sure I know what BPD is anymore. Now that we have pulmonary hypertension, now that we have pulmonary vein disease, now that we have hypertension causing left heart disease, it's probably a big mismatch of all sorts of different physiologies, which makes it very difficult to tease out as an endpoint. There's fairly compelling data that there is some relationship between larger shunts and some bad things. This is some work from Anna Selmer's group in Denmark. And the problem that we have is that when you think of the clinical symptoms associated with shunt, they're non-specific. increasing FiO2, increasing ventilation, changes in blood pressure. They're not precise. And it's not a big surprise then when you do studies like this. This is the UK study when they looked at the predictive value of the routine clinical signs, pulse pressure, heart rate, murmur, and the reliability of predicting a large shunt on day 7. Their predictive value was very, very poor. The only thing consistently associated with the presence of a large shunt on day 7 was metabolic acidosis, which makes sense to a certain extent. So here's my next question for you. Case number 1, baby on the jet. I apologize for people that don't use the jet, but I can tell you this is moderate jet settings. 40% oxygen. Okay, this is his blood pressure. This is his echo. Okay. Case number 2. Similar settings, maybe slightly more. FiO2, 40%. This is his echo. Okay. Who would like to take this? Okay, Stephania. I'm picking on you. I just saw you appear there, so.
Yes, I'm here.
Okay, so which of those shunts are hemodynamically significant? Case 1 or case 2? Is it 1, is it 2, or is it both? Or is it none? If you have a 25% chance of getting it right.
So I think this baby has higher like respiratory support, and I also saw that this ductus is a bit bigger than the other, and that there was diastolic reversal.
I think there's diastolic reversal in both. Let me just go back and see.
Oh, okay.
Oops. Yeah, so both of them have diastolic reversal, both have dilated left hearts, both have large unrestricted PDAs. So what's your answer?
I think I will say case 2.
Okay.
I think mostly because I think this baby is at least clinically worse than the other one. But also, I think
that's okay. Okay, so you think 2. Anybody else have any different opinion?
Hi, Patrick. This is George from Sunnybrook. I feel that both of them seem to be hemodynamically significant. Both of them are unrestricted. Both of them have aortic reversal, and the left atrium is dilated in both. Probably we may need some other parameters, some figures to say exactly, but probably both of them are significant.
Okay, okay. So let me ask you, George. So then I agree with you, and I would personally classify both as at least moderate, not higher volume shunts. If you were to choose to intervene, would you intervene on one or both?
Again, probably I may intervene in both.
Okay, okay. So anyway, I'm just playing with you guys a little bit because this is the same patient. Okay, and there's a point to this exercise. Okay. Case number 1 is the baby at 2 hours of life. Case number 2 is the baby on day 4 of life. Okay. And the point of the exercise here is shunts that are bad on day 7 or day 6 are probably also likely to be of concern somewhere in the first 48 hours of life. And this is the FIF's natural history study, which basically shows that, you know, in infants that have PDAs that close, they're not likely to have major disturbance in any of these echo parameters, whereas those that stay wide open have, as early as the first 48 hours, changes in pulmonary vein flow, left ventricular output, may have flow reversal in the arch, et cetera, et cetera. And this is very important because the traditional thinking, when I came to the US here, this program here was aggressive at treating the PDA, but the aggression started on day 7. And my first question is, what's magically happening on day 7? Why have we chosen that date? And it's come from nowhere. It's like most of the things in neonatology. Danny, let me ask you a question. How do you want to handle, because we've got 30 minutes to go. Like, I've got more slides. I can focus on some of the key things, or if you would like to have the last 20 to 25 minutes for people to ask questions, and then I can refer to some of the additional slides if necessary. Which would you prefer? Because I can see there's a lot of stuff in the chat that I haven't even looked at.
Yeah, most of that stuff I think we can address. I wonder about maybe taking 5 minutes to do maybe an accelerated wrap up, and then have another 10 minutes or so for questions. What do you think about that?
Yeah. So I can go to some. Let me just see what's the most important things. Let me just give me 1 second. I'll just go to some key parts of this that might be of interest to people. Okay, so I might have to stop sharing and reshare. Okay, so let me just present very briefly kind of what we do here. Okay, because that might be interest to people. So what we do here is we screen, and we screen between 12 and 18 hours. And depending on the physiology, we provide disease-specific therapies. So if there's heart dysfunction, we will treat with dobutamine. If there's pulmonary hypertension, we will use nitric oxide. Some people use 20, I use 5. And if there's a large left or right shunt, we will start the babies with Tylenol. And the reason that we chose Tylenol was because of many of my colleagues use early hydrocortisone, and some concern about the potential synergistic relationship between co-administration of indomethacin and hydrocortisone. But the rationale, let me just take a step. The rationale for why we intervene is based on, 1, data that prophylactic indomethacin decreases IVH. 2, evidence that prophylactic indomethacin also decreases hemodynamic instability in the first week of life. And we touched a little bit about this earlier on, is that in babies like the case we presented, who have a antecedent low cardiac output state with potentially low flow to the brain because the brain is perfused preductally, if the ductus remains open, as PVR falls, either because your lungs are getting better, because you've given surfactant or nitric oxide, you're going to have a reduction in PVR leading to an increase in pulmonary venous return and an increase in cardiac output. So this is very much a hypothesis. And here in Iowa, we have a incredible survival rates at 22 and 23 weeks gestation, as many people know. But can we get better? And I think that's one of the questions that we always need to ask. Can we optimize, continue to push the envelope and get better and better and better? And this is a center which believes in respiratory precision, nutrition precision. Now can we add into this cardiovascular precision? So our echo is based on the traditional markers that we use. So the pulmonary vein D wave, we look at the ETA ratio, the isotonic relaxation time, left ventricular output, and actually oftentimes we look at the ratio between left and right ventricular output, flow reversal in the arch, MCA Doppler, and so forth. We have a score that we use to help adjudicate. So if the patient has got a score of more than 6, we intervene. I'm going to skip this on here. Let me just go to this here. Okay, so Tylenol. So we don't know how Tylenol works. We don't. We have assumed that it's got a vasoconstricting effect on the ductus, but there's not a lot of muscle in the PDA. And when we looked at a cohort in Toronto, and we looked at with Jeff Rees in Vanderbilt at the preterm mouse ductus, we actually found it took very, very high doses to vasoconstrict the PDA. So the alternative explanation is it not working on the ductus, but is it working on the pulmonary vascular bed and causing an increase in PVR, or not allowing the PVR to fall, meaning you're diminishing the amount of left to right shunt across the ductus. And this work from Jacques Balek's group in Toronto suggests that there's a lot of potent, particularly pulmonary vasoconstricting effects in females and so forth. So we've just looked at our response rate to early Tylenol, and this is data from 100 infants. And of those 100 infants who were treated intravenously, starting on day 0, some of them got 3 days, some of them got 7 days. 54% of them were responders, and response was not defined as closure, but either as closure or the declaration of hemodynamic non-significance. And what you can see here is that from those that close, some of them still they remanifest, because closure isn't a guaranteed thing. There's functional closure and there's anatomic closure. And some of those that improved still needed retreatment. But what was most interesting, and Stephanie is on the call here, is our second-year fellow that did this study, was when we looked at the phenotype of the responders. It was quite interesting. Infants who were IUGR, infants who were hypertensive. Okay, there was an ethnicity effect, suggesting that there may be something developmentally either at the level of the ductus, in terms of maybe different muscularization of the PDA, or maybe a different pulmonary vascular response that might be influencing this. So this, again, hypothesis generating, but certainly interesting, and the data is relatively comparable to what we found within indomethacin. And again, this is IV indomethacin. The last thing I want to share with you is just the impact of the data, okay? And this is hot off the press. This is the last slide I'm going to show you. This is data from a lot of people who were involved in this very, very rigorous data collection. It reminds me of what Danny did in Toronto. But we looked at the modern epoch, which has 172 babies, versus the control epoch. And again, this is in a high-performing center, which has a survival rate of 22 weeks gestation of 60%, at 23 weeks of 78% or close to that. And what you can see is that in the modern epoch, there were some clinical differences. Trend towards lower gestational age, less females. There also was some interval changes in things like cord clamping, slightly more use of antenatal steroids. But what was particularly interesting to me was this is much, much sicker mothers. 3 times higher risk of obesity, 4 times higher risk of maternal SSRIs, and so forth. When you look at the data, what you can see just on Univare's analysis, there was a significant reduction in the composite outcome of death or severe IVH, trend towards reduction in death, significant reduction in IVH, survival rate free of severe morbidity, which is something to me is important. Having a little bit of grade 1 BPD is not necessarily a bad thing, but bad IVH, bad BPD, bad neck is important. Again, positive benefits seen here, reduction in neck, and obviously this is not surprising, early identification of the ductus, early intervention, the numbers of babies referred for surgery or cath closure was reduced. Now, what was most interesting was then we took this cohort, and there were many other potential competing confounders. We built a comprehensive logistic regression, interrupted time series analysis, and basically demonstrated that independent of gestational age, year of birth, or these other factors, that the presence of hemodynamic screening was associated with a 3.5 odds ratio of survival free of significant intraventricular hemorrhage. So I'm going to stop at this point and give you guys 15 to 16 minutes for questions. Again, I'm not telling you should go away and start screening, but I think we're at a point here whereby we need to now take these concepts and design trials. We would not be able to do a randomized trial here at this center, but other centers may be able to do this, to actually look at if you take this concept. And I am aware of a individual from a kind of a program in Chile who visited us, has introduced their program there and found a very similar effect, particularly on intraventricular hemorrhage. So, Danny, the floor is yours.
Thank you, Patrick. Thanks for a fantastic talk. I think everyone comes to your talks with 10 questions answered and 30 more questions that they need to get answered, because you've opened everyone's mind to various other concepts. So what I'm going to ask is for our guest attendees to write their questions into the Q&A, and I'll be moderating those. For our panelists, I encourage you to just actually raise your hand and I'll select you and you can ask your question live. There is one question that I think can be done in the meantime. Patrick, could you show your PDA score slide again?
Sure. Yep.
While
I think there's another question there, which is the assessment a full study? And the answer to the question is yes. So basically, within our program here, we do around, and people are going to probably collapse when they hear this, 1,700 echo consults per year, which is a huge, huge volume. So for our trainees, they get a lot of exposure. However, for all of our trainees, the less than 1 kilogram babies, we limit the imaging to expert people. So nobody starts scanning a 400-gram baby until they're very, very competent. So on the call, we have Pearl and Angelica, who are 6 months into the program. They've probably done, I don't know, maybe a couple of hundred scans, but they've not scanned anybody that's under 1,000 grams. They will, but the integrity of getting the information in an efficient manner, which limits the time on the patient, is important. So we do the full study, which has somewhere between 75 and 85 images. And I think this is important for us as a field. You know, the expert hemodynamic person can get that study done within 10 minutes, which is better for the baby. And I think it comes down to the fact that we're skilled at handling tiny babies. We can adjust to ventilation changes. We know how to adapt to the baby, and we're just smoother and more comfortable. So the score is basically built on these parameters here, and it's adapted from some of the other scoring systems. We published kind of a paper in JACE last year with Danielle Rios, kind of demonstrating a strong relationship between the score and increased risk of BPD. We add on to this the score plus the indexed PDA diameter. So if your indexed PDA diameter is 1.3 or 1.4, you get 1.4 points for that. So.
Okay, Eamon, please go ahead with your question.
Okay, thank you very much. So my question about the combination between the PDA treatment and hydrocortisone. So it's very clear with the endomethacin, but what about the acetaminophen or the ibuprofen?
Okay, so that's a fantastic question. I probably shouldn't have. Let me just share my screen again. So we go to that slide. Okay, so here's two things I want to tell you. So number one, okay, we have data, but the numbers of patients that we have made this radical decision on is very limited. So in one study, I think it was 4 babies versus 0 babies. And nobody has looked at the relationship with other non-steroidals. Not that I'm aware of. If they have, I would love to know about that. But we don't have a large cohort study yet. You can see from these studies here, they're still pretty small. All I will tell you, and again, this is not to be interpreted as you should not use hydrocortisone, but in the French centers where they have now made the Bull protocol their standard of care, their risk of spontaneous intestinal perforation in the early aggressive hydrocortisone treated population increased significantly. Here, even in our program, we had been evolving to a kind of something that was a little bowl-like, in which babies were put on hydrocortisone at birth and kept on it sometimes for 2 to 3 weeks. We started to notice an increase in spontaneous intestinal perforations, and we now have adapted our protocol to trying to wean these babies off hydrocortisone by day 5. And that allows us then that if we do need to give indomethacin on day 7, we can give indomethacin on day 7. And we've seen a significant reduction in the rates of intestinal perforation. So I'm still not sure how much of this is truly the combination versus the interaction between PDA plus hydrocortisone, PDA plus hydrocortisone plus nonsteroidal. Because in the model testing here, what they didn't put into the model was the presence or absence of shunt and how that modulates the risk of intestinal perforation. So I think we're going to see some interesting data out of France sometime in the next 1 to 2 years on this. But my advice would just be, I think until that data, we don't give indomethacin to babies who are on hydrocortisone. We don't do that. We wait a few days. I don't know how many days you should wait for. People seem to have interpreted it as 3 to 4 days. It's come from nowhere. It's kind of a made-up number. But for the other, to answer your question, I don't know. I don't know anything about the association with ibuprofen. Danny, have you heard anything about ibuprofen and
prophylactic hydrocortisone?
Yeah,
just the Bow trial. The Bow trial, they did exclude the concurrent use of early ibuprofen, but beyond 24 hours, the French sites were giving standard dose ibuprofen even to the babies who were in the trial. So obviously, some were placebo and some were receiving the prophylactic hydrocortisone, and there was no difference in rates of SIP or NET.
Yeah, like the other thing as well that's not is there's probably other factors going on here that are important to look at. So giving a nonsteroidal and hydrocortisone to someone who's IUGR, for example, or someone in which there's been a history of chorioamnionitis, in which they're a higher risk population, then again, the numbers are just so small, it's very difficult to tease out, the true effect. But again, it's one of these things that we have kind of adopted as certain cause and effect. And I'm not so sure that we can confidently say that combination is truly the sentinel factor. I think it's likely to be much more complex than this.
Thanks, Patrick. I'm going to take a couple of questions in the Q&A and then head back to our panelists. One of the questions is the presence of mannitol as excipient in Tylenol or paracetamol formulations a matter of concern from a brain point of view? I guess this is an additive to the preparation. Yeah,
so it's and again, there's a question about Tylenol and autism. Yeah, the answer to the question is, I don't know. I honestly don't know. If these things are real effects. Certainly from our cohort here, we have not noticed any negative effect on at least brain development. But time will tell. I think it's really, really important. We're learning the lesson that we need to change our thinking to beyond what goes on in the NICU to looking at lifelong health, whether it's heart health, lung health, kidney health, brain health. I think these things over time will become a lot more obvious. I also think it would be highly beneficial to be able to do early MRI on some of these patients. As I said, you know, it was particularly intriguing to me, the data here on the relationship between prolonged high volume shunt exposure and head growth. Okay, what is that about? Okay, how much of that is driven by the problem versus treatments for the problem? Certainly, one thing that's very interesting, and I think the relationship of the duct to the brain and brain flow is something we have very little idea. And one thing I see a lot of less of here than I saw when I was in Toronto is flow reversal in the middle cerebral artery. And part of that, and the hypothesis that we're starting to think about here, is that the brain is exposed to high flow. And typically early on, you don't see flow reversal in the brain, but you see it later in babies with prolonged shunts. Does prolonged exposure disrupt the vascular bed of the brain? Do we get increased endothelial thickening, increased muscularization of the middle and anterior cerebral artery, which then leads to increased resistance, which then is why you get late onset absent and reversed end diastolic flow? Because typically, those of you that look at a lot of babies for PDA closure, the babies with the most prolonged shunts have the highest cardiac outputs, meaning the brains have high flow, but they have reversal. So lots and lots of questions that we have to ask about. But the only way to answer them are well-controlled observational studies, interventional studies that define the patient populations very clearly.
Actually, there was a similar question about Tylenol and autism. I know that's been an epidemiological flashpoint, but any comments on that?
Yeah, I was just saying there, Danny, I think it's too early to say. I think time will tell. Certainly, I'm not aware of anything here from our center, but again, we've only treated 100 plus patients so far. But again, something to think about.
Thanks. Okay, Shiran, you're up.
Thank you so much. I was wondering if you could perhaps comment if you've seen any kind of difference in the efficacy of Tylenol in tinier babies, like the smaller preterm babies. Is it as efficacious as?
Yeah. So if you go back to that, I keep going away and I keep going back to my slides. So let me just go to that. Where is it? Where is Stephanie? Stephanie is on the phone. Maybe she can talk about her own study. Where is it? No, it's later. Okay, so if you look at the responders and non-responders, okay, these are small babies. So they're all less than 27 weeks gestation, okay?
Less than 29.
Right, thank you, Steph, okay? So so there's a few, but the vast majority of these babies are part of our screening protocol, okay? And you can see that, you know, the mean gestational age is in the 24 to 25 weeks gestation. It's not been obvious to the extent that it's a concern. Clearly, there's an effect, but it's not a guaranteed closure in all of these 64% of cases, okay? There are still some patients that relapse, okay, and need other therapy, okay? And if you look at, obviously, the rate of interventional closure, you can see here much lower in responders than the non-responders, which again is not a surprise. Same thing you would see with indomethacin, okay? But to me, as I said before, the effect of, you know, these maternal infant characteristics is particularly interesting. And it will be interesting to look from other centers that use early Tylenol, whether they've seen a similar effect. What's common to IUGO or maternal hypertension is some dysregulation of either the muscle in the ductus or muscle in the pulmonary vascular bed. One can hypothesize, is that why they're more likely to respond? Or is it genetically determined? I don't know. Did that answer your question, Chair?
Partially. It's just that I read a few commentaries and editorials talking about that the really tiny babies, like 20 22, 23, 24 weekers don't tend to respond to Tylenol as much.
Okay,
As
so
the- but-
Jeff, do you want to comment? What percentage of the population was 22 and 23 weeks? It's fairly high. I believe it's probably somewhere between 30 to 40% of this population is 22 to 23 weeks.
Yeah, I think probably like 40%.
Yeah. But that's a good question, and actually would be interesting to look at this data from a gestational age perspective, Steph, to actually look at the responder, non-responder rate, because people are probably going to ask you that question at 22, 23, 24, 25 weeks gestation. And I've seen the same thing, but that's not been our experience here. We've had many 22-weekers that the ductus is closed.
Thanks, Patrick. There's a question about how to manage the kind of borderline bidirectional shunts, I guess, during your hemodynamic screening. So the question is, when you scan early on, it's not uncommon to see a partial right to left shunt across the ductus, and would you still treat a ductus with a right to left shunt where the right to left component is about 30%?
Yeah, so again, everything depends on what is, one, the clinical state of the baby and what's the ambient physiology. So an infant who has 30% right to left flow, who is in 70 to 80% oxygen with a dilated dysfunctional right ventricle, we will not close the duct, okay? If there's any concern to heart function with any right to left flow, we will not. However, an infant that has some right to left flow with all of the markers of hemodynamic significance, we will treat, and we've not seen any problems. So it comes down to, again, the comprehensiveness of the assessment helps you differentiate the pathologic versus the supportive role of the ductus.
Okay, I think we have time for one last question, and that question is about what are your views about the Oscar trial? I know these are a bit controversial.
So number one, I've not heard the results of the baby Oscar trial. Again, everything depends on who is randomized and the purity of the patient population. And I think, you know, if you don't choose that a population with a high probability of the morbidities that you're likely to be concerned about, the likelihood of identification of benefit is going to be less. And in many ways, baby Oscar is a little bit like PDA Tolerate trial. And that's my worry, you know, and we here are part of the NRN trial, the PDA NRN trial. And people were comfortable randomizing the babies that they weren't worried about. That's all I will say. And therein lies the problem. And to be honest, if we are to answer the question, we have to be able to randomize patients that we're worried about. Otherwise, we will just spin our wheels the next 100 years. But I'm very, very enthusiastic about the pivotal trial because, again, it's not early intervention, but at least it will answer the question that if you mitigate prolonged exposure with certainty, can you modulate outcomes? And I think that's going to be important. I hope. Initially, the study was designed to randomize at day 14. I convinced Carl to randomize at day 7. I think it's okay to go to the cath lab at day 7. And that I think will give us some insight. Otherwise, early interventional trials are only going to yield good data is if they have a high probability that you solve the problem. And that to me is the most important question. Not what's the evidence for randomizing drug X versus drug Y, but what's the evidence of closing the duct versus exposed to a big shunt? That's what we want to know. Everything else is just messy.
Great, Patrick. First off, thanks so much. Obviously, a really enlightening talk for everyone. Thank you to our panelists, all of our hemodynamics trainees for joining us and for participating and acting as guinea pigs, answering your questions. I want to thank the guest attendees. I hope it was still a great talk for you, and thank you for your participation through the Q&A. I'd invite, we are going to be sending evaluations out to everyone who attended, and I know Patrick and we here would be grateful for your feedback. And again, Patrick, thanks for your time, and I'll draw our discussion today to a close. Thanks again to everyone.